So Melody Ryan is our next speaker, and Dr. Ryan received her PharmD and Masters of Public Health degrees from the University of Kentucky. She completed a pharmacy practice residency at Duke University and a neurosciences fellowship at the University of Kentucky. She has appointments as professor in the College of Pharmacy, Division of Pharmacy Practice and Science, and at the College of Medicine, Department of Neurology at the University of Kentucky. Her practice site is a neurology clinic at the VA Medical Center in Lexington. She earned her certification in geriatric pharmacy in November of 1998, and she attended attained board-certified pharmacotherapy specialist status in 2000. She currently serves as the immediate past president for the Academy of Pharmaceutical Research and Science of the American Pharmacists Association. And she has also served, similar to our first speaker, as a speaker here at the Updates in Therapeutics Pharmacotherapy Prep Review Course since 2003. So please join me in welcoming Dr. Ryan.
Thanks. Okay. Thanks, Lisa. And just for the record, I did attend the course twice before I got up the nerve to actually do it. All right. Welcome, everybody. Let's buckle up. I have nothing to disclose, and we're going to go on a whirlwind tour of neurology. So let's start with our first case. TM is an 18-year-old new patient in the pharmacy where you work. He presents a prescription for carbamazepine 100 milligrams BID with instructions to increase to 200 POTID. Currently, he doesn't take any medications and does not have any drug allergies. During your counseling session, he tells you he has to have blood drawn for a test in 3 weeks. So which common potential adverse effect of carbamazepine is best assessed through a blood draw? Is it leukopenia, renal failure, congestive heart failure, or hypercalcemia? Okay, I'm seeing all blue, and that is correct, leukopenia. So if we look at carbamazepine adverse effects, some common ones are rash, which can be serious, including Stevens-Johnson syndrome, SIADH, aplastic anemia, thrombocytopenia, anemia, and leukopenia, so a lot of blood dyscrasias. Okay, so 1 month later, same person comes back with a new prescription for lamotrigine 25 milligrams with instructions to take 1 tablet daily for 2 weeks, then 1 twice a day for 2 weeks, then 2 tablets BID for 2 weeks, then 3 tablets BID after that. He says he's discontinuing the carbamazepine because he developed a rash a few days ago. So, which is true? The rash is likely caused by carbamazepine because the rash often has a delayed development. The rash is unlikely to be caused by carbamazepine because carbamazepine rash usually presents after the first dose. The rash is probably not caused by carbamazepine. It's probably attributable to carbamazepine-induced liver failure. Or it's probably not carbamazepine. It's probably carbamazepine-induced renal failure. Okay, seeing a lot of blue again, and that again is correct. The rash is probably due to the carbamazepine because often those rashes are delayed anywhere from 2 to 8 weeks after starting the drug. So just because it's not after the second, third dose doesn't mean it's not the medicine. Most rashes for antiepileptics can include just a simple rash, can include Stevens-Johnson syndrome, can include anticonvulsant hypersensitivity syndrome. So a lot of serious things. In the case of carbamazepine, the recommendation for testing is now available for some genomics testing for HLA-B star 1502 allele in patients who are of Asian ancestry, including South Asia. And those patients have a 10-fold increased risk of rash if they carry that allele. There's another allele that currently there's no recommendation for testing, but is sometimes being tested for, and that's HLA-A star 3101. And usually those patients are Caucasian, also increased risk for rash, but it's not as well quantified, and there's no recommendation at this time for testing in everyone. Okay, so same patient wants to know why it's necessary to increase the dose of lamotrigine so slowly. And you say, it causes dose-related psychomotor slowing. It causes dose-related renal stones, dose-related paresthesias, or dose-related rash. All right, good. It does cause dose-related rash. So the rash with lamotrigine is a little bit unusual because it is related to the starting dose of the medication and to some extent how fast you go up on the drug. So that's why we have a really slow titration schedule. And you want to be especially careful in pediatric patients that you're getting the right dose. And there's even a 5 milligram tablet to use so that you can get the appropriate dose for those kids. It's also the reason it takes 1,000,000 years to get up on the dose when you're on valproic acid. Okay, so the titration schedule there starts 1 every other day, so it's very, very slow. So you want to pay special attention if you've got somebody who's also taking valproic acid. And the rash can be anything from fairly mild to quite serious in nature. It does have a black box warning, and we do recommend stopping the medicine if the patient does get a rash. So it's really important to titrate slowly so that you don't lose the use of a medicine that might be potentially useful for a patient. Okay, now we're going to switch patients. JG is a 34-year-old who has been maintained on carbamazepine extended release 400 milligrams twice a day for the past 2 years. She's had no seizures for the past 4 years, but today she has status epilepticus. So, what do we want to do first? Diazepam, lorazepam, phenytoin, or phenobarbital? All right, I'm seeing more of a mix here. The right answer here is lorazepam. So let's talk about why that is. So a couple of principles for status epilepticus. We always want to give an emergent medicine to stop seizures immediately. So in this case, that means a benzodiazepine. So right there, we know it's either going to be lorazepam or diazepam, right? Then we want to follow up with an urgent medicine to prevent recurrence of seizures. Our urgent medicines usually are things like phenytoin, fosphenytoin, phenobarbital, valproic acid, now levetiracetam, sometimes you see. Generally, all of our medicines that we use for status, we want to give something that works quickly, so we usually use parenteral medicines unless there's some really extenuating circumstance. And lastly, remember, we aren't using a neuromuscular blocker except in the case where we need to intubate a patient or for some other reason. But just stopping the muscular effects of the seizure doesn't stop the activity in the brain. So using a neuromuscular blocker is never the right answer for status epilepticus. But why not diazepam? Well, for lorazepam, it is the drug of choice for first-line therapy for status epilepticus. And why that is because it's more lipophilic, less lipophilic than diazepam. Now, on the surface, that doesn't make much sense, okay? But when we think about it, that means the diazepam, it does get into your brain a little bit quicker than lorazepam does, about 10 seconds, okay? So a little bit quicker. But it also comes right back out of your brain because your brain isn't the fattest place on your body, okay? So it goes all the other places that you have adipose tissue on your body, and frankly, your butt doesn't need it. Okay, so we want the stuff to stay in the head a little bit better. So that's why we use lorazepam. So I'm making a big deal about that because I think when you look at like the half-life, when you look at all the things, the properties associated with it, it doesn't make a lot of sense until you think about it that way. All right, number 5. SR is a 37-year-old patient who began taking phenytoin 100 milligrams, 3 capsules, PO at bedtime 6 months ago. He's experienced several seizures since then, the most recent of which was a week ago. At that time, his concentration was 8 mics per mil. The treating physician essentially doubled his dose, 300 BID. All right, a nice easy one right over the plate for you. Okay, what do you think his serum concentration will be today? Will it be 10? 14, 16, or 20? And all I see is yellow, and that's because yellow is the right answer. Good job. So just a reminder that phenytoin has Michaelis-Menten kinetics. Did anyone have a seizure just when I said the words? Flashbacks to kinetics. And it is also highly protein bound. So we aren't going to expect a dose proportional increase because of the kinetics properties with Michaelis-Menten. And then the high protein binding, of course, leads to a host of drug interactions as well. All right, back to it. SS is a 22-year-old woman, always had episodes of zoning out, Recently, one of these happened when she was driving home after an examination. She had a non-injury accident, but this prompted a referral to a neurologist, and she got a diagnosis of absence seizures. So what should we use to treat her? Is it phenytoin, tigabine, carbamazepine, or ethosuximide? Okay, right, so ethosuximide is the right answer. So I think it's easiest to remember the drugs that we can use for absence and know everything else is for like partial. Okay, so for absence, it's things that work at the T calcium channel. So if you see that as part of the mechanism of the drug, it's probably going to work for absence. Okay, so there's a little free tip today. Okay, but our drugs of choice, usually we think first about ethosuximide and then valproic acid. Particularly, we would think about valproic acid if the patient had any other seizure type as well. Okay, so if the patient has, a mixture of absence seizures and some partial seizures or some other kinds of seizures, then valproic acid would be a great choice. Second-line therapies might be clonazepam, might be lamotrigine. Some people might use onisimide, things like that. Okay, number 7. JB, 25-year-old man, history of seizure disorder. He has been treated with phenytoin 200 2 times a day for 6 months, and his current concentration is 6.3 mics per mil. His neurologist decides to increase his phenytoin to 300 2 times a day. Which adverse effect is he most likely to experience related to the dose increase? Is it drowsiness, acne, gingival hyperplasia, or rash? Most people are saying drowsiness. Some people are saying gingival hyperplasia because that's the only thing they remember about phenytoin. But it is drowsiness. And why is that? Well, we have two kinds of adverse effects that we expect to see with phenytoin, those that are dose-related and those that are not dose-related. The dose-related things include nystagmus, remember the eyeball moving, okay? The ataxia, drowsiness, and cognitive impairment. Those are things we're going to see as we increase the dose. Things that can happen at any dose are things like the gingival hyperplasia, hirsutism, or overgrowth of hair, acne, rash, hepatotoxicity, coarsening of the facial features. All of those can happen with any dose that you're giving. MG is a 15-year-old boy with a diagnosis of juvenile myoclonic epilepsy. He's been prescribed sodium divalproate. On which adverse effect are we most likely to see in him? Is it oligohydrosis, renal stones, alopecia, or word-finding difficulties? I'm seeing mostly green, and green would be the right answer for this. So for valproic acid, just to review some of the highlight adverse effects, hepatotoxicity is rare but can happen. Nausea and vomiting, pretty common, and one of the reasons it's Depakote, right, because it's coated to help prevent that. Weight gain can happen pretty commonly. Interference with platelet aggregation can happen. Pancreatitis can happen, although it's rare, and alopecia can happen. GZ, 26-year-old woman, presents with a 6-month history of spells. The spells are all the same. They all start with a feeling in her abdomen that's hard for her to describe, but it rises toward her head, and then she believes she loses consciousness. After a workup, she's given a diagnosis of focal seizures evolving to bilateral convulsive generalized seizures. The neurologist is considering initiating either carbamazepine or oxcarbazepine. So, to compare the two, which is the most accurate statement? Is it oxcarbazepine causes more liver enzyme induction than carbamazepine? Oxcarbazepine does not cause a rash. Oxcarbazepine does not cause hyponatremia. Or oxcarbazepine does not form an epoxide intermediate in its metabolism. Clearly, oxcarb is close in some of your all's minds. Yes, so it's D. There is no epoxide intermediate in the metabolism. It is an enzyme inducer, but it doesn't induce its own metabolism. So it's different from carbamazepine in that regard, but it does still induce the cytochrome P450 enzymes. Okay? Hyponatremia is more common than with carbamazepine, and blood dyscrasias are a bit less common. So that's kind of the differences there. I do want to spend just a second to remind you that it is not a prodrug of carbamazepine. I hear that a lot. It's not a prodrug. It's just structurally similar. Okay. When we see this same patient 6 months later, she says she's 6 weeks pregnant. Congratulations. She's had no seizures since beginning drug therapy. So what do? Immediately discontinue her seizure medicine, and give folic acid, continue her seizure medicine, or change her seizure medicine to phenobarbital. Oh, no one wants to raise them up in the air. Look at this. Okay. All right. A mixture. Okay. But in this case, I would continue her seizure medicine. So let's talk about recommendations for women who have childbearing age with epilepsy. So during their reproductive years, the recommendations are the patient should take the best drug for the seizure type. I know inherently that makes sense, but I've also seen a lot of people say, well, ethosuximide has a B rating, so let's give them ethosuximide. And you're like, well, they don't have absence seizures, so not going to work. Okay? So we've got to choose a drug that works. Of course, we prefer treatment with monotherapy whenever we can. Okay? Sometimes that's not possible, but if possible. We want to make sure we're discussing issues with decreased contraceptive efficacy if we've got an enzyme-inducing medication. Okay. So you can use, of course, non-hormonal forms of contraceptives. You can also go with a higher dose of the estrogen component in a combination oral contraceptive. And in all of these women, we want to make sure that we're supplementing with folic acid of no less than 0.4 milligrams per day. A lot of times people will go on and do a prenatal multivitamin even though they're not pregnant to get in 1 milligram. Okay. So what about during pregnancy? Well, theoretically, what would happen is that medications would be optimized before the pregnancy happens, because most of the problems that happen in pregnancy with the anti-epileptics happen early, even before the woman usually knows she's pregnant. Okay. So ideally, we would have conversations with patients well before they became pregnant, make sure that they're planning pregnancies, and so that we can optimize medicines before that happens. Unfortunately, I guess in the last 20 years, I've had exactly 2 patients call me before they were pregnant. So usually what happens is they call after, right? We want to avoid valproic acid if we can because of an extremely high risk of spina bifida. With that drug. And that risk is becoming more and more clear as we have more data from the pregnancy registries that are being done. So we want to avoid that generally if we can in women with childbearing potential. We want to avoid polytherapy during pregnancy, of course. We do allow breastfeeding with all of our drugs, so there's no reason they need to not breastfeed. And we do monitor serum concentrations. Okay, so hopefully before, generally about once a trimester until we get into the 3rd trimester, and we do at least during the last month, and then postpartum because, of course, everything is changing there kinetically. Okay. We don't have to monitor every single drug's concentrations. You can if you want, okay. But, of course, the ones that we usually think about monitoring. Okay. So kind of thinking back to our case, why didn't we change anything? Any damage that we're expecting from that drug is probably already done at that point. Okay, so it's better not to try to emergently take someone off a drug and precipitate maybe status epilepticus and so on. So very rarely do we actually take someone off if they're already 6 weeks to 8 weeks pregnant. Okay, number 11. LR, oh, we're going to do stroke now. Time for stroke, okay. All right, LR, 78-year-old man who presents to the emergency department for symptoms of right-sided paralysis. He states that these symptoms began about 5 hours ago and have not improved since that time. He also has hypertension, BPH, diabetes, erectile dysfunction, and osteoarthritis. What is most likely his risk factors? Is it erectile dysfunction, age, and osteoarthritis? Sex, diabetes mellitus, and osteoarthritis, BPH, diabetes, age, and sex, age, diabetes, sex, and hypertension. Oh, you all were fast on the draw with that one. All right, that's right. Age, diabetes, sex, and hypertension. So let's think about stroke risk factors and what they are. We have non-modifiable and modifiable and somewhat modifiable ones. So the non-modifiable ones are obviously things we can't do anything about, so things you're born with. Age, race, sex, low birth weight at birth, and family history. So those we can't change for people. The reason diabetes, obviously we can modify diabetes, the concern is we don't really know how much that helps prevent stroke risk, but we do, of course, control for diabetes possible. And then the things that we know are modifiable, and that's a pretty long list now. So we've got hypertension, one of the easiest ones to modify. Smoking makes a huge impact if we can get them to stop. Estrogen use, AFib, about 5% risk per year, so quite high. Coronary artery disease, carotid stenosis, dyslipidemias, obesity, physical inactivity, and sickle cell anemia. And we go on. Peripheral artery disease, pregnancy and in the immediate postpartum period, a patent foramen ovale, and depression. So those are the things that we know that are modifiable and we have good data on. A little bit less well documented are alcohol abuse, hyperhomocystinemia, drug abuse, hypercoagulability, periodontal disease, acute systemic inflammation and infection, sleep apnea, metabolic syndrome, and migraine with aura. Okay, so there are a bunch of things. Obviously, we concentrate on the things we can change, and you saw in that list a whole bunch of things that pharmacists are involved with. So, thinking back about our patient now, is he a candidate for TPA? Yes. No, he's too old. No, his stroke symptoms began too long ago. No, his diabetes is a contraindication. All right, everybody's on board with this one. Yes, they began too long ago. So what are our criteria? So just about 6 weeks ago, I guess, there was a new guideline put forth that looks at each of these criteria in more depth, and they have modified a few things fairly recently. For one thing, they dropped most of those special considerations if the patient's between 3 and 4.5 hours. So I'll be pointing out the differences kind of as we go through these. So it needs to be within 4.5 hours of stroke symptom onset, and I would consider that a pretty hard deadline because we know that those patients who were treated in some studies at 5 hours and at 6 hours had worse outcomes. Okay, so that I would consider a pretty hard deadline on that, 4.5 hours. And we know that actually they have more intracerebral hemorrhage, but their disability scores at 3 months are improved compared to people who did not get the TPA, even with considering that they might have had intracerebral hemorrhages. And our dose is a bit different than we use in MI, so it's 0.9 milligrams per kilo with a max of 90 milligrams, no matter how heavy the patient is. 10% of that is given as a bolus, and then the rest is given over an hour. And our goal is door to needle time, 60 minutes. So our exclusion criteria, now there's a whole bunch. Mainly the thing to keep in mind here is it's things that increase the risk of bleeding, as you might expect. Okay. So if you have bleeding, probably that would be a no, okay, on TPA. If you have had recent surgery, head trauma, or stroke within the last 3 months is usually how that's interpreted. If you've had major surgery or serious trauma within the last 2 weeks, and this is a new caveat, if you consider the risk of bleeding outweighs the risk of possible benefit. Okay, so that's kind of the new trendy thing to put on the end of our exclusions now. GI hemorrhage within 3 weeks or a structural GI malignancy. Blood pressure greater than 185 over 110. Now, you can lower that. If you lower it with drugs or whatever in the ER, the patient should be stabilized before treatment, and it should be maintained at less than 180 over 105 for the next 24 hours. The glucose should be not less than 50 and not greater than 400 unless we can normalize that. If the patient has had an arterial stick at some site that you can't compress, then you need to be careful about that, and that's 1 week limitation on that. If the patient has a tumor or an AV malformation or a huge aneurysm, we're going to avoid that. If the patient's being actively treated with anticoagulants, we want to avoid those things. If the patient has infective endocarditis, or if the patient is pregnant, again, if the benefits that we anticipate don't outweigh the risk of like intrauterine bleeding. All right, he was taking no drugs at home. What choice is the best secondary stroke prevention for our patient? Is it sildenafil, a drug that I keep thinking I'm going to take out because I can't really pronounce it, Silexcox, aspirin, or warfarin? A little bit of a mixture. I think the best treatment here would probably be aspirin. So when we think about secondary stroke prevention, now this is a little different from primary, right? So primary, we think about AFib, but other than that, we're going to modify risk factors. When we talk about somebody who's already had a stroke, secondary prevention, yes, we're still going to, of course, look at all those risk factors and treat whatever we can. Patients sometimes get carotid endarterectomy if they have pretty significant blockage in their carotids. And then the guidelines don't really distinguish between which of these you should start next. And I know there are individual studies that indicate one over another. There are a lot of those. But in general, the guidelines suggest that you can start aspirin, sustained-release dipyridamol, ticlopidine, clopidogrel, silostazol, or warfarin. Okay. Generally, I would avoid warfarin because of the excess monitoring that we have to do on this. And there's no proven benefit, but there is a much higher risk of bleeding, of course, with the warfarin. So that's why I would not choose that for our patient here. Okay, so you're the pharmacist at a community pharmacy and you get a call from MW, who is a 60-year-old man recently given a diagnosis of AFib. He's concerned about his risk of stroke because his friend, who also has AFib, asked him what dose of warfarin he's taking, and he's not taking any warfarin, and he wants to know if he should. He has no other medical conditions, and he takes atenolol only for ventricular rate control, showing you peer pressure is alive and well at any age. So after we say you should talk to your physician about this, what should we tell him? You need warfarin treatment to prevent a stroke. You do not need warfarin, but you should take aspirin and clopidogrel. You do not need any drug therapy at this time. Or because you have AFib, nothing can help you. So sorry, move along, yes. Okay, I'm seeing a lot of C, I'm seeing a lot of indecision. All right, but I would say C is the right answer here. So in the case of primary stroke prevention, okay, we're going to use our CHADS VASC score. So remember, you've seen this before, of course, CHADS, congestive heart failure, hypertension, age over 75, diabetes, prior stroke or TIA, vascular disease, age 65 to 74, and sex category. Okay, CHADS VASC. So it's 1 point for most of those things and 2 points for a previous stroke or TIA, and that's why they get the little 2, okay, or age over 75. And total 0, then we don't have to give any therapy. If it's 1, you have a choice between an oral anticoagulant and aspirin, or no therapy. And if it's over 2 or 2, we need to give the oral anticoagulant. Okay, in our patient's case, he was 0, so we would choose no therapy for him. LS, a 72-year-old woman with a medical history of hypertension, diabetes, renal failure, and AFib. She presents to the anticoagulation clinic for her initial visit. Here's an easy one for you, just so we get a resting point, right? Okay, what's her target INR? 1.5, 2, 2.5, or 3? And I see nothing but green, and that's the right answer, 2.5 or 2 to 3. Okay, so that was stroke. Proceeding on, again, at our whirlwind pace, we have Parkinson's disease. So LS is taking carbidopa-levodopa 25/100 4 times a day, and trihexyphenidyl 2 milligrams 3 times a day for his Parkinson's disease. His wife reports he's often confused and experiences constipation. He has trouble talking because he has a dry mouth. What will we do to fix this? Increases carbidopa-levodopa, increases trihexyphenidyl, decreases carbidopa-levodopa, or decrease his trihexyphenidyl. No doubt about it, right? Okay, so we want to decrease that anticholinergic. Thinking about adverse effects of our anti-Parkinson's medicines, everything that's not an anticholinergic is a dopaminergic agent for our treatments. So the dopaminergic things that we're going to see with everything that increases dopamine or dopamine effects are nausea and vomiting, orthostasis, and hallucinations. Okay, so we're going to see those things over and over and over again with all those drugs. The anticholinergics we could all recite like a mantra, right? We could be like dry mouth, urinary retention, dry eyes, constipation, and confusion. Right? We all know that. Okay. All right, 6 months later, our patient comes back. He's concerned that his carbidopa-levodopa dose is wearing off before his next dose is due. What would you do about that? Would we increase the dose of carbidopa-levodopa, decrease the dose, increase the dosing interval, or decrease the dosing interval? Okay. Good. We should decrease the dosing interval. Sometimes I think the way that those are worded with dosing intervals is a little confusing. So make sure if you see that you take the time to really think about what it means. So good job. So we have two things that we kind of think about with carbidopa-levodopa. We have wearing off and we have on-off. How do we tell the difference? Well, wearing off is before it's time for your next dose, you have symptoms come back. On-off is more like a light switch. That's why it's called on-off. So suddenly, without warning, you have your symptoms return. Okay? So wearing off, fairly straightforward and simple to treat. We use controlled release formulations, or we give the doses more often, or we add a catechol-O-methyltransferase COMT inhibitor, or we add a dopamine agonist. So we can do a lot of things that help that. On-off, a lot more difficult to treat. We can try adding those things. Okay, we can try adding COMT inhibitors, selegiline, rasagiline, the dopamine agonist. We can try distributing dietary proteins a little bit differently. So there's a lot of things we can try for that. They have varying degrees of success, and apomorphine is the thing that's usually used at that point. Okay, PJ is a 57-year-old man with an 8-year history of Parkinson's disease. His current drugs include carbidopa-levodopa, 50, 200, 4 times a day, and tacopone, 200, 4 times a day, amantadine, 100 milligrams, 3 times a day, and he presents to the clinic with a reddish-blue discoloration on his lower arms and legs. Which, if any, of his drugs cause this? Is it carbidopa-levodopa, entacapone, amantadine, or none? This is probably venous stasis. Okay. All green, and that is correct, amantadine. So when we think about some of our special adverse effects with our dopaminergic Parkinsonian agents, amantadine is levodo reticularis. You remember that one? I tell you what, that has been on every standardized exam I've ever had to take in my life. So consider this like a little free gift from me to you today. Levodo reticularis is amantadine. Okay. So just a reddish discoloration, sometimes bluish. Sometimes you have a little swelling with it. If you stop the drug, it goes away. If you don't, nothing bad happens to you still. Okay. So, except that you have a reddish blue discoloration of your lower extremities, but other than that. So other things that we need to think about is special adverse effects with the different agents. The dopamine agonist, generally well tolerated. The one that we have that's currently ergot derived, so that's bromocriptine, can have some fibrosis associated with it, and for that reason we really aren't using much bromocriptine at all anymore. Okay, but that is its main thing there. The COMT inhibitors, that's tolcapone and entacapone. Entacapone's the one we usually use. Diarrhea can occur, and sometimes that can be delayed for several weeks even when we start the drug. And then the urine can become discolored with the entacapone. It becomes kind of a darkish orange color, so something to tell patients about. Okay, case 19. LL is a 47-year-old man with Parkinson's. He takes carbidopa-levodopa, 50, 200, 4 times a day, and he recently noticed an involuntary twitching of his left foot. This is termed a dyskinesia, so what should we do about it? Do we add ropinirole, add selegiline, increase the carbidopa-levodopa dose, or decrease the carbidopa-levodopa dose? People want to decrease the dose, and I would agree with you. That's the great thing to do there. So when we think about dyskinesias, this is another more long-term adverse effect of carbidopa-levodopa. And these are just involuntary movements that happen. Often they're choreiform, but they can be things like twitching and things like that. What we do is we try to decrease any drug that increases dopamine. Okay. Sometimes that's a lot easier said than done because usually people don't get on the dose that they're on just randomly. They get on it because they needed it, right? So we need to kind of be careful about that, but sometimes we can reduce a little bit. Another thing that we can do is add amantadine. So it's not known exactly why that works. It's thought maybe it helps with the storage of dopamine and its release a little bit better, but that is somewhere else that we use amantadine. Okay, CA, a 57-year-old white man just retired from the New York City Fire Department. He's been experiencing tremors in his right hand that have become progressively worse for the last 6 months. He has difficulty walking, he also has backaches, and he no longer is playing golf. In addition, he's losing his sense of taste. He's given a diagnosis of Parkinson's disease. So what would you prefer as treatment for this man? Is it trihexyphenidyl, entacapone, apomorphine, or ropinirole? Seeing some indecision there. For this person, I would start with ropinirole. Okay. So how do we know what to do? All right, so anticholinergics, generally the only thing we're going to use them for is tremor. Okay? They don't really work for any of the other symptoms. So if the patient has tremor but has other symptoms, we're probably going to use a different drug. Okay? If the patient has other symptoms and it's under pretty good control and just has a little bit of tremor that they want to get rid of, we might try an anticholinergic there. Okay? Or if they're really early in the disease and they mainly have tremor, we might do that. But in this case, he has a lot of other things. He's having problems walking and things like that. So we're probably not going to use an anticholinergic. COMT inhibitors, the one that we have right now, doesn't cross the blood-brain barrier. So the only way it can work by inhibiting that enzyme is on the levodopa. So once it's crossed, it doesn't, it can't work on that. Okay, so you have to give it in conjunction with carbidopa-levodopa. Those have to be given together. Now, in the future, if we have a drug, a COMT inhibitor that does cross the blood-brain barrier, it may work there too, but right now we don't have that. Okay? And then apomorphine is usually only for severe on-off syndromes, so we wouldn't use that as an early therapy. Okay, going to headache. How many people have a headache? All right, MR is a 34-year-old woman, has throbbing right-sided headaches. She experiences nausea, sonophobia, and photophobia with the headaches, but no aura. She usually has headaches about twice a month. She's hypertensive. She's morbidly obese. She takes an ethinyl estradiol progesterone combination oral contraceptive every day and hydrochlorothiazide, 25. She has a diagnosis of migraine. What's the best drug for prophylaxis? Would we choose propranolol, valproic acid, amitriptyline, or lithium? Okay, I'm seeing propranolol, and that's what I would choose as well. So let's think about when we should use prophylactic agents. So if we have a patient who has recurrent migraines that interfere with the daily routine, if they're frequent, if they can't use acute therapy, so they have some reason, chest pain, something like that, where they can't use a triptan, for instance, the patient wants to, and I have to say that one outrules almost anything. If the patient's willing to take a drug every day, I feel like their headaches are bad enough to warrant a drug every day. Okay? The cost of the acute medicines is problematic for a patient, or they have an uncommon migraine presentation. So somebody who has one-sided paralysis, for instance, with their migraine presentation, that's going to be somebody who's going to get treatment for stroke a lot of times, right? So we want to make sure that we're not doing that. So that's a good person to prophylax. So what do we do? What do we think about as principles here? Of course, we want to use the lowest dose that's effective for our agent. We want to make sure we give an adequate trial before we say the patient's not responsive to it. In most of these cases, that's 2 or 3 months of treatment. And then we want to consider what other disease states the patient has, both as additional treatment, for instance, in this patient with hypertension, and as contraindications or problems with treatment. In the morbidly obese patient, for instance, we probably wouldn't give valproic acid because of the weight gain associated. So prophylaxis is listed in your handout. There are a number of things we can use. Provatriptan, even though we would usually consider an acute thing, it can be used for short-term prophylaxis. For instance, if you have a woman who's got menstrually associated migraines the week before, the week of her menstrual period, she has migraines, that's somebody we might use something like frovatriptan in for that short term. Metoprolol, propranolol, timolol are the beta blockers that actually have data to support it. Most beta blockers would work, though. Peptides are something that's kind of new in the guidelines, and valproic acid and topiramate. Okay. There are a lot of other things that are used as well, but those are the things that have some data. The acute treatment is also in your handout. I wasn't going to spend a ton of time on that today. SR is a 54-year-old female homemaker with squeezing, band-like headaches that occur 3 or 4 times a week. She rates the pain of the headaches as 7 out of 10 and finds that acetaminophen, aspirin, ibuprofen, naproxen, ketoprofen, and piroxicam really don't work so well. And she wants to take a prophylactic drug for these headaches. So these are tension headaches. What will you choose? Same choices: propranolol, valproate, amitriptyline, or lithium. Okay, I'm seeing a lot of amitriptyline, and that's also what I would choose for this patient. So our list is a lot smaller for prophylaxis than it was for migraine. When we look at tension headache, tricyclics are used, and botulinum toxin can be useful when it's injected in the forehead and sometimes the neck muscles. Acute treatment, usually we're looking at simple analgesics. And I would caution you here to keep in mind that we have things like rebound headache, also called medication overuse headache. So if you have someone who's using a simple analgesic more than 3 times a week, you really start worrying about possibly getting medication overuse and rebound headaches. And then they would develop this chronic daily headache that is extremely difficult to treat because the treatment for that is stop the drugs. And no one likes that. Okay, DS, a 49-year-old male computer programmer, describes lancinating right eye pain and tearing several times a day for 2 to 3 days in a row. He then has no episodes for 2 to 3 weeks, but then they return, recurrent episodes. In the office, we give him oxygen by nasal cannula, and his pain is relieved. He has a diagnosis now of cluster headaches. Same choices. What do we want to use for him? And everybody who was like, why is the lithium on there? It's for this patient. Okay. All right, so for cluster headache treatment, prophylaxis, usually we don't use lithium, but you can. We have patients that we use it in. But verapamil tends to work pretty well. Melatonin has been shown in a few studies to work. A few patients get suboccipital injections of betamethasone, and then lithium is our other option. Acute treatment here, the problem is it's very hard to find a treatment that works quick enough because these headaches, they're very, very painful, but then they kind of go away pretty quickly too. So oxygen is something we use. On the triptans, we usually want to think about things that have faster onset formulations, like sumatriptan has the injectable. Okay. We also have seen some studies with intranasal lidocaine. Frankly, the way that they administer it is difficult, and until it would come out in like a spray formulation, I think it would be hard to expect patients to hang their head over the side of the bed and drip it in slowly over so many minutes. I mean, it's just difficult to do. So we don't see many patients wanting to do that. Okay, and one on acute treatment. So MK, 44-year-old woman, right-sided headaches, moderate intensity, accompanied by severe nausea and vomiting. Which triptan is best to treat her migraine headache? Is it almatriptan, naratriptan, rizatriptan, or sumatriptan? Okay. We have several people that think it's sumatriptan. We have others that are like they're all triptans. Right? Okay, so the reason I think sumatriptan is best for this is because it does have some non-oral routes of administration, and these others don't. So sumatriptan also has intranasal, and it has injection sub-Q. So those are some options if you have somebody with really significant nausea and vomiting. Okay. And now we're going to slip in a statistics question. Watch how I do this. Okay. One of the neurologists you work with has recently read a meta-analysis of migraine treatments. He's most interested in the outcome of sustained relief from headache at 24 hours. But he's confused by the numbers needed to treat analysis. So he shows you this table. All right, ready? So what's the best interpretation of these data? Is it elatriptan 80 is the most effective agent? Ergotamine plus caffeine is the most effective agent? elatriptan has the most adverse effects, or ergot plus caffeine has the most adverse effects? Okay. All right. And that's correct. Elatriptan is the most effective agent. When we look at the formula for number to treat, what we're really saying is how many patients do we have to treat to have one patient who has efficacy? Okay? So here's the formula, the percent improved on active therapy, the percent improved on placebo, the difference there over 1. So the lower the number is, the fewer patients we need to treat to have one where it works. Okay? So that's why the lowest number wins on that one. Number needed to harm is done in a very similar way. That one you want the highest number, right? Okay, MS. We're getting near the end. SF is a 33-year-old African-American woman of Cuban descent living in the Miami area. This morning, her right leg became progressively weaker over 3 hours. She was previously healthy, except she had a broken bone when she was 13 and a case of optic neuritis when she was 25. Which method is best for treating her exacerbation? Is it interferon beta-1a, glatiramer, mitoxantrone, or methylprednisolone? I see some confident D's going up, and D is the right answer. So to treat exacerbations, we use steroids. We use corticosteroids. You can use IV. The usual dose is 1 gram a day. You can do it all at once. You can divide it up for 3 to 5 days. And the patient should start seeing some improvement at least by day 2 on that. You can also use oral prednisone. The usual dose is huge, right? It's 1250 a day, given every other day for 5 days, 5 doses, so 10 days total before you're done. You can use ACTH. For a while there was a shortage on methylprednisolone IV, so that was used some. Generally we don't use it because of the expense. And we do know that recovery is the same with or without a taper. So unless you have an extremely long course of steroids, we usually don't need to taper with just a three-day course. Okay, same patient. What do you want to do to prevent exacerbations? Would we prefer to give her interferon beta-1a, interferon beta-1b, glatiramer, or any of the above? Okay. And most people are good with any of the above, and I would say we could do any of those at this point. Okay, so she elects to start interferon beta-1b and wants to know whether she can prevent or minimize some of the adverse effects. So what advice is best for her here? Is it always give the injection at the same time of day, lie down for 2 hours after the injection, rotate the injection site, or use a heating pad on the injection site? Yeah, everyone wants to rotate. Always good advice. Yeah. Okay, so as far as injection site reactions, with our self-injection medicines, these are by far the most common things that we see. They're more common with the sub-Q products. Some things that will help, you can try bringing the medication to room temperature before injection. You can try icing the site before they do the injection. And of course, rotating between all the possible sites and then within the site. So what I mean by that is if you're going to inject your thigh, you want to inject different spots on the thigh each time. So BB, a 33-year-old woman with a recent diagnosis of MS. Her neurologist wants you to discuss with her potential medications to prevent exacerbations. While we're talking, you find out that she and her husband are planning to have a baby in the next few years, and she's terrified of needles. So what do we want to do? Glatiramer, mitoxantrone, teriflunomide, or dimethyl fumarate? Okay. All right, I'm seeing some indecision here. So dimethyl fumarate would be my choice here. So the first two are injections. So the first one is glatiramer, is a self-injection. Mitoxantrone, of course, is the same mitoxantrone we use for chemotherapy. So it's an infusion. Of course, there's still a needle involved. And in that case, also, we would be concerned about the risk for birth defects in somebody who is wanting to start a family. Teriflunomide is an oral drug, could be used, except for the pregnancy risk, and it has an extremely long half-life. We either have to wait about 2 years for it to be out of the system before trying to conceive, or do accelerated elimination processes. So those are kind of the options for that. So dimethyl fumarate, although we would want to stop it before pregnancy occurs, and we want to talk extensively about that, we could use and then stop before conception. Now, if she weren't so afraid of needles, gluteramine would also work there the same way. All right, that's what I've got for you. I'll be up here if you need me.